Come back from wherever you are. All right. So we have some questions, and I'd like to start with our distance participants. I think we have questions from both St. Cloud and Rochester. We have a couple written here, but it looks like maybe we have our folks up on the screen. So Rochester or St. Cloud, do you want to pose your questions?
Sure. Can you hear us?
We can hear you just fine.
Perfect. Well, we were curious about what we're calling the tipping point. And originally, we were thinking of that in terms of maybe the number of patients that were served, or the number of nurses that were involved, or maybe it was a special impact that happened that really sent the innovation across the country. But as we talked amongst our members here, the question got a little bigger. And that really is that the tipping point involved tipping away from a bureaucracy to a plurocracy, and we maybe made that word up. But what we mean is something that is simple and people-driven. And so then the question became, how will it continue to grow without becoming a bureaucracy again?
Okay, so that sounds like a three-layered question. What is the tipping point in terms of leveraging a change? How did it grow in terms of its social network, and how does it stop itself or monitor itself or regulate itself so that it doesn't morph into a bureaucracy, right? So you have comments about that?
About the growth, the theme that started got a lot of attention in different articles, and a lot of nurses recognized their current situation and the possible situation. So in a lot of places in the country in 2007, discussions started. And I went to a lot of kitchens and living rooms where I talked evenings with nurses about nursing and about this model. And every evening I got back home and I phoned my wife and she said, "How was it?" And said, "I had a very special evening with very inspirational nurses." And the next day they phoned me and they asked me, when can we start with the team? So that happened all the time, and all these nurses have their own networks. So when we started in one region, what you saw was that other nurses in this region also wanted to start. So it was some kind of flu, I think.
Some kind of flu.
So that's, I think that most of the nurses thought that you couldn't talk anymore about nurses in the way we did, because they said the message from the organizations they worked at was that because of the economical development, or because of the structure of the organization, or because of all kinds of reasons, they couldn't do their work they wanted it to do. So that was the main reason that these nurses themselves, they were kind of advertising all the time, and we got a lot of articles. And there was this television crew who came to make some kind of small documentary about us, and it was on television. We were only with a small group of nurses, so it had a big impact.
So it's like 1, 2, 4 all, right? Starts with 1, goes to 2, and then 4. Thank you. Any other questions from our distance viewers?
Yes, St. Cloud had a question.
Please.
In our current economy, how do you think these organizations would sustain in the long term, since so much is tied to reimbursement, like Medicare? And then what's your ratio of private pay to insurance, or do you guys utilize private pay and insurance in your model?
Yes, what we try to do is, on one hand, we have the payment system, so we are paid in different ways. And say we try to avoid that the payment system is influencing the professional nursing system. So we split it. We said if we have enough money to do what is needed, then it's okay. So, and what's important is to have a very stable economical model. So all these teams, they know what their results are. So every team knows what the incomes are and what the costs are. So we made a very simple economical overview. So every team can also, every month, they can just count, we did it well or we did not so well, and what can we do to improve it. But if it's stable, and for example, productivity in our organization is a very strong signal for if it's going well or not. And that's for 3 years, 59%. And once a year we say, okay, if we have this 59%, then we have enough money coming in to do all the things we need to do. And then we also can save some money for when the reimbursement system is changing again. And then we can, because we also decided in 2010, we got 4 million euros not paid by the care offices, the insurance company. And we said, okay, that's a pity, but we're not going to change our policy. We just keep on doing what we are doing. The profit was a little bit lower than we expected because of that, but we're not for profit, so it's not important. So we have now enough profit. This year we have, I think, 2012 we had 11 million euro profit.
Wow.
And every nurse got a bonus. So that's also because we are doing it together. And we have now some reserve for the coming years for when there is something changing in the system. But it's very important that we keep on doing what we think we should do based on a very simple economical model. And we keep the influence from outside outdoors. That's what we try to do. And on the other hand, we have to think, and therefore also the economical side is quite important. We have to think to keep all the time in advance. So we have to show the insurance company what we are doing. And we have to negotiate about the results and how we can be paid for what we are doing. So not wait and react, but be proactive and show and let them know that what we are doing have better results than what they were paying for.
Okay. Any other questions from our distance guests?
What do you mean by psychiatric health care?
What I mean by psychiatric house care is psychiatric home care. No, what we do is we have small teams with psychiatric nurses, social workers, and community nurses. Teams of 3-4 people. They are supported by a psychiatrist and a psychologist, and they support people in their homes. So what you see is that when sometimes people have to go to a psychiatrist or to a residential place, sometimes they say it didn't need to happen if they get the right support at home. So what we try to do, and it's also the same with youth care, if you support the families and you keep the people in the system and you also involve the system in getting a better support system around the client, then people don't need to move to a residential situation, and also they don't need treatment from a psychiatrist. So this was the message from the psychiatrists themselves. They said, we got a lot of patients who really didn't need to come here if we had more preventive activities. Mm-hmm. So that's, I hope it's a clear answer.
Okay. Yeah. Good, thank you. So now we'll turn to our audience here, and we have our roaming microphone folks. So If you have a question, please raise your hand. There's one in the back, and wait for the microphone to come to you.
So in a situation where we're looking at wanting to do more integrated care, and I realize that you're a nurse talking, and this is for nurses, but how do you see the role of because I think it's just awesome what you're doing, and the idea of how do you see the physical therapist, the physician, the occupational therapist, all of us who really are trying to ease the burden of suffering in our communities and our societies coming together and really partnering in this kind of an endeavor?
We started, I think, 3-4 years ago with combining the physiotherapists and occupational therapists, connecting to the teams. So we have, I think, now 300 teams who have a structural cooperation with these therapists. And they have meetings every 6 weeks about the patients they are involved together. With family doctors, we have a very close relationship. And a lot of teams, they have almost daily contact with the family doctors because they're sharing the same patients, like the terminally ill patients. There's a lot of communication about treatment, and it's a very big part of what we are doing, so it's 20-25%. The idea of creating networks around people is also to involve all the informal caregivers, also the volunteers, also other people who can contribute to the solution. So every team has 20 to 25 different relations in the neighborhoods. And they use the relations at on the moment it's useful. So I'm not supporting networks which are just talking about the networks. So it has to be about the patient and it has to be useful. So there are all kind of different virtual networks around patients, and these teams then nurture these networks in a way that they can use it when they need it. So that's the idea about, and then also we try to involve, the next step is to involve also patients in the web, the web which is used by the nurses. We also want that the patient has a bigger role in, for example, planning the activities, discussing about their situation, and also involve families, relatives of the patient. Okay?
Good. Scanning. Yes, there's one back there. Wait for the microphone, please.
Can you tell us, how are you collecting outcomes, and what types of outcomes are you looking for?
Am I looking for? We started in 2007 with outcomes which were very global, in the sense that we said we want to show that the satisfaction was higher, satisfaction of the nurses was better, and also the costs, amount of hours were less than the average other organization. So we did 3 researches, and at the same time we started to think about how can we focus on outcome in more structural way. So that's the reason that we started to discuss about the Omaha system. It's also the first time I was in Minnesota. I think it was 2008, 2009, the conference.
Could you just say a little bit about what the Omaha system is, so people know what
the Omaha system, we were looking for a system which supported the daily work of the nurses in a way that they were not bothered by this system, but they could use the system to do their work in a better way. And we found that the Omaha system is a classification system of problems, interventions, and outcome. And Karen Monson, can you tell Everything about it.
Great.
So what we try to show is that on different problems, different patient groups, if we do these kind of interventions, that the outcomes will improve, the quality of the delivered care, but also the quantity. So what we already showed is that if you focus on self-care, self-management of the patient, and you also involve the environment, that the period of care people needed can be shorter. So that's one of the advantages, and also the reduce of costs for the payers. So, and on the other hand, we wanted to have a system that gives us more information, more knowledge about what we are doing. So at the moment we only know, or we last 10 years we only knew how many hours care was delivered, and if these hours delivered good solutions, we didn't know. So now we have more discussion about how can we use this information to develop standards and develop best practice. So that's what we're now doing. We have this with the government. They support us in this experiment that we can focus on using this Omaha system, and we can skip some other administrative rules. So now we're trying to change the system from a production-focused system to an outcome-focused system.
Very cool.
Okay?
Other questions emerged from groups? Shirley, we'll wait for the microphone.
Thank you. I'm not sure if you had this issue or this problem to deal with at the beginning, but our question was around how do you incentivize or motivate nurses to be the leaders? In this country, the Institute of Medicine report on the future of nursing came out and said that nurses need to be equal partners and be leaders in decision-making with patient care. And how did you motivate, or was that not an issue, the nurses to do that, to take that leadership role, as opposed to a system being built and then nurses fitting into the system?
No, I get this question a lot, these kind of questions, and I say we didn't do so much. I think we should think about doing less. So, because I think nurses are motivated, and this intrinsic motivation is very strong, and we should try to avoid all kind of barriers. So, if you create a context where nurses can take responsibility, can be responsible for everything they are doing, they will do it. So, and what we see is that it's only growing. So they arrange, we have this two nurses, four nurses from Minnesota coming to Holland, and they've seen these teams in practice. And what you see is that these teams throughout of the years, they grow in what they can do, and they take responsibility for everything. So what happens is they support each other very much. So the nurses in the team, there should be this atmosphere that they trust each other and they are concerned about each other, but also between teams. So they learn a lot of each other, and they're very proud about what they're achieving. And because they are working in these small teams, in these villages, in this neighborhood, in the cities, they see that it's their achievement, not mine. So I'm just trying to avoid all these difficult things from outside the world, so that they just can do what they think they should do. So.
And one of the things I heard in the interview was the fact that a lot of these nurses were disenchanted with their work as it was in the bureaucracy. And so they knew that there was something better out there, and you offered them an invitation to explore something better. And so they were maybe moving away from something to moving towards something else. And so I think that moving away from pattern, moving toward pattern is an important motivator as well. Sometimes when things get really bad, you got to get out.
Yeah. So we had a lot of good role models. I think that's also quite important, that you see that in these teams, when the first nurses are good examples, that it sets the standard in the team. So you see that this behavior, everything is normal just to do these things. And I think what we also try to do is just talk about it. So we had, the first years we had all kind of meetings, and also this year we have 5 conferences, 5 days, and 2,000 nurses are coming a whole day and discuss things together, share knowledge. And every time the idea is that if you take the lead, then the environment is reacting on you instead that you are reacting on everyone. And so if you want to do something, just do it. That's all the time. I thought it was from Nike.
Nike, just do it. Just do it.
So that's, but I think there was, when I started as a community nurse, I thought it was a very strong point that you just could arrange something when you thought you had this, a few people with dementia, and you thought it was good to arrange some kind of training for the relatives, how to deal with this. Then you started some evenings and you said, okay, we're social worker coming to advise, and then you discuss sometimes with the family doctors what to do. And it was a continuously way of trying, doing some new things, and also experimenting sometimes.
Yes, sort of in middle over there.
Well, I think this is really exciting, and I think that Minnesota is actually at the right spot right now. Our hospitals have just started within the last year of being fined for hospital readmissions. And I know I teach RN to BSN completion programs, and our students are saying, well, there's all these job opportunities that are opening up in the hospital for case management, 10, 20 or more. And while that's a good start, it's in the hospital, and we need to move out into community, and we all know that that's the reality. And so I think that we really could, with our system set up as it is, we don't have the socialized medicine, we don't have the same culture. I think that, it sounds like you're much more supported within that setting. But I do think that we have opportunities here that this information and your data that you have, because we all know that data drives everything. So I think that we could really develop important plans that we could go to our medical system then and say, put a team in the community, use those resources that you're trying now as case management within the hospital setting. Take that, put that into a team, and let them try for a year and let them show that, the data will come back to support that the outcomes are improved and the cost will be effective for that purpose. So I think we're at a great point, and I'm glad to see you back. Thank you.
Good advice.
Good advice. Yes, there's one over here on the left, my left, your right, probably.
I have a question about the uninsured and reimbursement for the uninsured, and I'm sure you know that in the United States we have 10% or whatever, 50 million people who do not have coverage. We're hoping with the new Affordable Care Act that those numbers will diminish, but we don't know how all of that's going to work out. And I'm wondering about how in a place where there's so many individuals who don't have access to health care, how this kind of service could be reimbursed.
Yeah. Yes, I think we have to deal with the system as it is, and I think you should accept it and find ways to support also people who are not have access to services. And in Holland, we also do a lot of activities where we are not paid for, but we say, okay, if we are paid enough, then that's no problem. So I think my philosophy is that
Someone here?
I very much appreciate your concept of enough. Being a Dutch American and having 2 passports, the concept of enough, I think, is something that is not well understood in the United States, and I think by many people considered anti-American, fundamentally, very fundamentally goes against the principles of capitalism and greed. What suggestions do you have to have these new nurses truly understand the fact or the concept of enough? Not always having to grow, not having to have higher salaries, not having to get more in a society that is so deeply rooted in growth and advancement, financial advancement.
Yeah. Yes, I think the only thing you can do is just talk about it. So what we do also in Holland, but also in Japan, is just talk about these things and just ask them what the motives are, and then think about what's a good reward for what you're doing. So what we did also in Holland is that we pay more than other organizations. So we think nurses should be more rewarded. But then if you say it and you have this agreement with each other, then the discussion should be closed. Because otherwise, a lot of energy is put in all these discussions about salaries. And so we said we want to pay a good salary, and everyone who wants to work agrees with the salary and with the other conditions. We have a lot of opportunities for education, so we have a lot of secondary circumstances. And then by making it a standard, you don't have to put a lot of time and effort in all these discussions. So one of the elements of the model is that we are not going to make exceptions. So that's the reason that we have a very small head office. So also on the financial side, we standardize everything. So we only have 4 people on the financial administration. And we have now a turnover of 230 million euro. So if you try to standardize all these HRM things and quality things and finance things, then you don't need so many people. So that's what I would try to find out. And I'm quite convinced that talking with these nurses, that's not going to be the biggest problem.
One in the back, one to the side here.
I have a question about the team. If maybe you could give an example of what a team looks like? And the second part to my question is, in this country, there are different nurses. There's advanced practice, there's BSN, there's a variety of different, whatever word you want to use to describe it, educational levels, I guess. And so with the advanced practice, there's more autonomy. And clearly in the model you're describing, there's a lot of autonomy as well. So my question would be, if you could maybe give an example of not exactly a typical team, but maybe just a team, and who they are and what they look like, what their backgrounds are, just just kind of maybe a little story that would maybe help to better understand the that kind of composition of team.
Tomorrow I will show some pictures of teams. Then you can see their faces. Now I understand there are the average team is consists of 10 till 12 nurses. 70% are registered nurses, and 30% is assistant nurses, but with a lot of experience in home healthcare. So, and these registered nurses, there are 2 levels. We have the nurses who did their education in the hospital, and we have the bachelor nurses. So we have 1/3 of each. So, and that's very good combination in the teams because of the patient groups we have to deal with. So what you see is that we have, for example, a lot of patients coming from hospital. We have patients who are terminally ill, just 20%. We have patients with chronic diseases who need care, and we have patients with dementia. And of course also patients with in vulnerable situations with comorbidity and different kind of problems. So then the idea is that all the nurses can be responsible for all kind of patients. They are responsible for example, 5 or 6 patients. They're the personal guide of these patients, and they take care that for their patients, not too many other nurses are coming to their houses. So they do also responsible for the coordination. But the idea is that with these 10 nurses, you can also deliver 24 hours a day care, and also the teams are 24 hours a day available by mobile phone. I will tell more about it tomorrow, but it's okay for now?
Thank you.
Yeah? Okay.
And somebody in the back.
Is this on? Yeah. All right. The question, I think, is our original question was focused really a lot on what some of the other questions have been focused on, is which we're all looking to get to that consumer-driven paradigm versus a payer-driven paradigm. And with our markets the way they are in our economy, we're very payer-driven. And we're very siloed up because of all the different systems and all the different competing interests within those systems. And so as I was thinking about it, and I heard you say, and I like your story about the fact that when you didn't agree with it, you just had to leave. So the question for you is, should we all, as nurses, leave our systems to create a new entity that serves the community health and really the consumer-centric? And would that then get the energy behind a real system change?
You rabble-rouser, you.
Yes, I think a lot of nurses left in Holland, but they left before there was a good alternative. So you had in Holland first you had 2 alternatives. You had the big traditional home care organizations, and you had the more commercial agencies, and you couldn't choose in something for something different. So when we started, we noticed that a lot of nurses like to work in an environment which is focusing on ethical issues and is not economical driven, and is also very focused on development. So I think you shouldn't just leave, but I also think about an alternative. But the alternative is there, so you can all leave, of course. You are.
Crisis of conscience.
I always said everyone is very welcome. We don't have, for Buurtzorg, we didn't have a strategic plan or something that we are focusing on a goal for the next year that so many nurses have to come. We always said everyone who wants to come is welcome. And because we have this hospitality, I think a lot of people want to come. So every month we have 200 new nurses coming to work for us. And then we say, you're very welcome, and they get some presents and so on.
Do you need a visa to work there?
No, you can just join us. And but I think what is very exciting is what already different questions were about is how can it work in the circumstances in United States. But perhaps you can contribute to this. Thank you.
Do we have 3 questions? 4? 2 more questions. Okay. Oh, cluster of questions. Okay. Wait for the microphone.
Stopping us from doing that right now?
I don't know.
Good question.
But,
Courage. Yeah.
no, I think by creating this model and this concept, it took us 2 years. So I don't think it sounds easy, and I think it's quite simple to do, but to think what's needed to take care of all these different perspectives. So of course you have to deal with the system. You know that you have to have a story for the payment system, for the insurance companies, for the Medicaid, Medicare. You have to influence the network. So we had a lot of people in different influential places in Holland who adopted the system, and even sometimes we didn't know that they were supporting it. We had people around our government who were very supportive. So that's also the lobby work you have to do. So you should take time to think about how it can be done here, and we already are doing some preparations for how the model could work here. And then I think when it's working, I expect that what's happening in Holland can happen in every country, so that a lot of nurses will join if it gives them better circumstances.
I'm particularly interested in dying and end-of-life care and the ethical issues around that. And in my opinion, the Netherlands is way ahead of us with aid in dying in the Groningen Protocol. But I'm wondering if you could help us envision what your model would look like in terms of end-of-life care here. There was recently, just in this month, I think, published in JAMA, where people are dying now more at home here and in nursing homes, but which is a change from acute care hospital. They are still having many episodes of ICU admissions right before dying. The cost is astronomical. So this shift from sort of chronic care, if you would, to when you're going to stop pursuing care. But can you say anything about what your model would might help us with in terms of end-of-life issues?
I think it's a long-term issue. As you said, we had for 30 years this discussion in Holland about how to deal with terminally ill patients who are terminally ill, and I think that what you see is that how stronger the primary healthcare system is, the more people are dying at home. We have this same discussion in Japan. 60% of the people want to die at home, but only 15% has the opportunity. So all people are helped in hospitals or nursing homes. So I think the first step is create the conditions that people can die at home. So, and therefore, I think what I heard till now is that also, like in Holland, the home care facilities work also with a lot of lower educated nurses. And I think you need higher educated nurses to give this, deliver these facilities. So, but I think it's a discussion with the nurses who are going to start here, what is possible. And I think this connection, which Yvonne already said, with the hospitals can speed up on these patient groups the possibilities to deliver this terminal care at home. So that's, for now, my ideas about terminally ill patients at home.
Jamie, were you going to ask a question?
I would like to just tag on to that a little bit about end-of-life care, because I think that we have a model that has proven to be pretty effective. Minnesota, about 85% of people say they would want to die at home, and the most recent statistics show that we're getting better around that. We now have about 40% of people who actually are able to die at home. And hospice is really delivered by a nurse-led care team, and we've had great success with that in showing that we can improve the patient experience, we can improve the outcomes, and we can reduce the cost. So I'm wondering if there's a way for us to take that as our bright spot and say, we've done this to some degree, and now how do we build on that and move it outside of the hospice realm? Because we have some experience to show that nurses can lead these teams, and it's really focused on customer and patient needs and wants. And so how do we take that model and expand it, which I think, and maybe I'm incorrect, is sort of the direction you're going with the teams that you have?
Yeah. But if I may ask a question to you, is it, do those teams only serve patients who are terminally ill?
In the hospice realm, they do, and it's somewhat limited because Medicare allows us to only serve those who have a life expectancy of 6 months, which is a barrier because many of actually about 50% of the patients that are served by hospice die within 14 days. Yeah. So it is focused on the terminally ill, and that's a huge barrier that's, again, reimbursement driven.
Yeah. Yes, the model of Buurtzorg is based on taking care of all patients in a neighborhood. So what we said is we focus on generalists, and very important is that you involve these networks in these environments to be part of the solution. So I think it would be interesting to see how the experiences and also what you already developed can be used in developing this system. But I think you have to make a choice in focusing on different patient groups or focusing on the neighborhood. And I think for the long term, creating strong communities, strong neighborhoods with teams who take care of all the patients in this neighborhood has more advantages than focusing on different patient groups.
I agree, and I think probably one of the challenges that we have is within our systems, we work so much in silos. And so now instead of taking hospice and expanding that model, now we have palliative care teams. So, you know, I think it's just such a fascinating concept and a great direction for us to move to break down those and care for the neighborhood, and no matter where they are in their continuum.
I'll take this opportunity to put in a plug. The Densford Center is sponsoring the Florence Wald Lectureship with the Minnesota Hospice and Palliative Care annual meeting, and we're bringing Dr. Judy Pace to do a pre-conference workshop on April 14th on pain management and end-of-life care. So you can get information about that from the Minnesota Hospice and Palliative Care website or the Densford Center website. So thank you. Jamie, and I think this will be our last question because I think we're coming to the hour, right? Is it almost 10?
I was curious, talking about end of life here, the last few questions. A larger gap exists outside of hospice, and that is how the family and other relations to that patient approach that understanding and maybe moving upstream a little bit. With the team, the Buurtzorg team you have in place now, what influence have your nurses had in advancing discussions towards advanced care planning, late life, disease support, and have there been any measures of changes in perception of quality of death?
No, what I already said is that we started with this more global research on consequence for all patient groups, on quantity and quality, but most focusing on satisfaction. And the outcomes were that the satisfaction rates were the highest in the country. And in fact, we want to use now the OMA system to focus more on the detailed data. And so I can't say so much more about that.
Okay. Well, thank you very much. It's time for a break. And then after the break, we'll come back and we'll eavesdrop on a conversation of a group of nurses that went to the Netherlands, and we will hear about their experience. So we'll continue the conversation after a while.